What is a thing but not a thing at all? Nothing. Okay. What's a cake's position in baseball? A cake's position in baseball. The batter. Like that one? And the last one I have for you, somewhat more relevant to this class. What did the femur say to the patella? What did the femur say to the patella? I need you. All right, that's all I got. That is all I have for you. Except a little bit more. I have liver diseases today. So let's talk over liver diseases. And true to form, we're going to do an overview. So the first question I have for you, it's kind of a review question, is which of the following is not a function of the liver? Let me real quickly fix that screen. Which of the following is not a function of the liver? Take a minute. What does the liver not do? Does it make proteins? It does. Does it store fats? It does. Store or detoxify? Absolutely. It's probably one of the more well-known functions of the liver. We'll talk a lot about this today. Does it store glycogen? Storage form of glucose? Absolutely. Does it help to manufacture bile? It does. So all of these are functions of the liver. The liver is a pretty critical organ. That's kind of the whole point of this particular slide, is to really highlight the importance of the liver as we navigate today's lecture on liver diseases and why it's kind of a big deal. The liver is pretty important to us. We can't live without it. We can't function without the liver. And so its utility is extremely valuable. So let's talk about a couple of terms before we kind of dive into liver diseases. Bilirubin. So bilirubin is the yellowish breakdown product of heme catabolism. Remember, from the picture in the upper right, heme is a group that's found in the red blood cell and specifically has an iron molecule that oxygen has an affinity to. Iron is highly attracted to oxygen or vice versa. This is why iron oxidizes or rusts when it's left out. Oxygen finds the heme group and binds. Well, the red blood cell has a lifespan, and so it recycles and recirculates, and we have to get rid of the heme. Well, if we don't break it down well enough, then we lead to what's called jaundice, or a yellowing of the skin and the eyes. Like the whites of the eyes turns a little yellow because we have hyperbilirubinemia. So bilirubin is the breakdown product of that heme molecule. If you have too much of it in your blood and you're not recycling it, you become jaundice. Now, a couple things about jaundice. We have young infants. There's two populations that become jaundice. Number one is premature infants, so preemies. Often the liver is not fully operational. It's not fully functional, and so they'll have a lot of bilirubin buildup, and they become jaundice. And we can actually use light therapy. Certain wavelengths of light will actually break down that heme molecule and lessen the effects of jaundice in our infants. The second population where it's more problematic because it's so broad-based and the liver's not kind of coming on, it's actually shutting off, is in chronic alcoholism or cirrhotic liver conditions that we'll talk about today. And those individuals develop jaundice as well because their liver is failing. Okay. Cholestasis. Cholestasis is a term associated with the liver, where there's a biliary pigment that's visible in the canaliculi in the hepatocytes because you don't have a lot of bile flow that's happening. So bile is not flowing actively from the liver to the duodenum or the small intestine, and we get a lot of cholestasis. Stasis meaning lack of flow. There's a term known as portal hypertension here. Portal hypertension is when collagen is deposited over these liver sinusoids and disrupts the architecture. That architecture that's disrupted is of the vascular system, and you kind of see the portrayal of the vascular network in this lower middle image. Highly vascularized organ, but the portal system is highly dependent on venous blood flow. And so this can become hypertensive with portal hypertension. So you get excessive blood pressure on the portal circulation in the liver, and you prevent flow from happening normal physiologically. Coagulopathy. Coagulopathy is the liver synthesizes all the known coagulation factors except for one. It doesn't make factor 8. But when the liver is not functioning, you have clotting issues known as coagulopathies. And then hypoalbuminemia is low levels of albumin. Low levels of albumin. Albumin is a very large protein that circulates in the bloodstream. In fact, it's the largest protein in the bloodstream. It's what encourages the reabsorption of fluid into the venous circulation. And so albumin manufactured by the liver, if the liver is failing, then you would be hypo or under albumin content or hypoalbuminemia. And you're going to have a lot of fluid out in the periphery, a lot of accumulation of fluid in the tissues. That's another term that's not listed on here, but that's known as ascites. A-S-C-I-T-E-S, ascites. And ascites is just that, and we're going to look at that. That's an accumulation. That's an accumulation of fluid in the tissue or in the peritoneal cavity, in the peritoneum, in the belly area, because you're not making enough albumin, and so the water is not being reabsorbed back into the venous circulation. Ascites. Now, finishing this out, the last one, hepatitis as a broad term is an inflammatory disease of the liver, typically caused by viruses. It's named for the viruses. The hepatitis name is also the name of the virus. So there's a hepatitis A, there's a hepatitis B, or a hepatitis C. But those viruses are separate from other types of inflammatory diseases. Like you could have alcoholic hepatitis, which is not a viral infection. It's trauma or damage to the liver repetitively, chronically, and now the liver is in a state of chronic inflammation. So we'll look at kind of all of these, viral hepatitis as well as alcoholic hepatitis. We're going to focus mostly on the alcoholic hepatitis. Okay. Which organs connect to the liver via veins? Small intestine, stomach, esophagus, spleen, everything but the esophagus, or all of the above? Thoughts? That's right. It is all of the above. Absolutely. So check our feed real quick. Very good. Very good. So relies on the venous circulation, just like what we talked about. Very, very critical in detoxifying venous blood. And what's interesting is the venous blood is highly pressurized or low pressure. It's low pressure. So this is a low pressure filter. Whereas the kidneys are high pressure or low pressure. The kidneys, the renal circulation comes off of the aorta. So that's arterial pressure. So the liver and the kidneys are tapped into filters on both sides of the circulatory system, which is kind of interesting. So this term ascites that I wrote on the board, how does it develop? Well, it kind of begins with portal hypertension. So there's something happening with the liver, and the liver is failing, and you get this dysfunction, and so you stop producing albumin, that large protein that circulates in the venous circulation and creates a colloid osmotic pressure where there's high protein inside the bloodstream. That means water is going to follow solutes via osmosis. So fluid is going to want to move back into the venous circulation because you have a high concentration of protein. Does that make sense? Let me say that again. The venous circulation reabsorbs fluid from the tissues because there's left inside of the blood stream protein, large amounts of protein. In fact, albumin being the biggest is trapped. It can't get out between the endothelial spaces. So even if you get transudase and exudates leaving on the arterial side, you would have albumin in the venous circulation, which is important because that high concentration of protein in the venous circulation creates a pressure gradient where water is going to move to where the area of high protein is located inside of the venous circulation. That's called colloid osmotic pressure. It brings fluid back as a reabsorption of fluid into the circulatory system. And that's how we keep from having swollen feet and legs and fluid in our bellies. So when albumin doesn't work, or isn't manufactured, I should say, you get these ascites, or an increase in the accumulation of fluid in the belly, in the peritoneal cavity. Often what will happen is that you'll get these varices, which are distended veins in the patient. And I'll show you here a picture in a second. Because this is a classic example or indication that the patient is in liver failure. So this recall of hypotension is in existence, then you get a lot of renin release. So if the blood pressure is too low, then you release renin. And in a situation of portal hypertension and ascites, you're going to have low blood pressure. The liver has hypertension, but the vascular network outside of the liver is hypotensive. So if it's hypotensive in the arterial tree, you release renin. Renin released by the kidney is going to conserve water and try to increase blood pressure, right? So these are sort of the feedback loops that we have in play. And that increase in blood pressure then allows more fluid to leak out, less fluid to come in. And so it's a deleterious positive feedback. You with me? It's not helpful, and it propagates the condition to be more aggressive every time it happens. So what does this look like? Well, this is a patient. This is a chronic alcoholic patient, unfortunately. You can see the distended belly or the distended peritoneal cavity. There's a tremendous amount of fluid accumulation in the belly or in the peritoneal cavity. I mean, so much that this patient's laying on their back in a supine position, and the belly is still extremely distended. You can also appreciate in this picture the ascites, or I'm sorry, the varices. The varices are these distended veins that you can identify as the network, the venous network is doing its best job. But there's just no albumin inside of the venous circulation. So, an interesting story. When I was young, growing up in the 80s, I remember hearing we would do these news clippings. So like the news clippings from current events, like newspaper articles, you cut out and you'd come present your topics. I think I've mentioned this before. And I remember one of the topics was a huge drought in Africa, like in Ethiopia in the 80s. And there were starving children. And so all these articles were all about these kids that didn't have any food. And the pictures that they would show were confusing to me. Okay, maybe they're confusing to you if you've seen this. Like these pictures of these children in impoverished nations that are starving have these, what I thought when I was a kid, this is horrible, but I thought, well, they're fat, right? They got these pot bellies. How could these kids be starving? I couldn't connect the dots. So let me ask you, what's the answer to that? What is similar between these two clinical cases of what we've just talked about? And what helps to explain this condition? Take a moment. Yep. Yeah. These kids are starving so much, they don't have enough protein. The liver isn't able to keep up. So by not manufacturing enough protein or consuming enough protein in the diet, they very quickly end up with ascites, fluid in the peritoneal cavity. So it's a telltale sign of starvation. Protein levels are too low. I mean, I didn't understand all that physiology when I was in fourth grade, and the article didn't really explain it to me. I'm not sure if it did, if I'd understand it, but I don't know, maybe that helps connect some of the dots that you've always kind of wondered in the back of your mind. But I feel like it's kind of a topic you can't really ask, it's not socially acceptable to ask that question. Like, why are you showing pictures of those kids? Are they really starving? Absolutely. In fact, this is called Kwashiorkor disease. It's a form of malnutrition that is specifically to low protein in the diet. And so some of the symptoms are ascites, like what you're seeing here, a change in skin pigment, significant decrease or loss of muscle mass, diarrhea, failure to gain weight, failure to grow, failure to meet pediatric milestones, and fatigue, listlessness, hair loss, or hair change even before the loss. The hair becomes very brittle because keratin is a protein, and that's mostly what hair is made of. Okay. So in the remaining time in the lecture, we're going to kind of hone in on alcoholic liver disease. It's somewhat prevalent in the world. And for those of you that are future clinical practitioners, healthcare providers, first responders, I mean, you'll deal with this issue in the future, unfortunately. So let's talk a little bit about what this looks like. So alcoholic liver disease. We really have kind of three overlapping conditions. And the way I want to present this is it's not really like you move from a normal liver to stage 1 to stage 2 to stage 3. There's kind of this fluidity or this interplay between the different stages of liver disease. Now, that being said, a cirrhotic liver is the worst stage. It is irreversible because you have a fibrotic liver that has scarring, has collagen deposition. The inflammatory insult to the liver has been so aggressive over time that you replace normal functioning tissue with fibrotic scar, just like what happens in a wound on the skin, just like what happens on the heart with a heart attack, just like what happens in the brain with stroke. The same thing can happen to the liver. And when the liver fibrotic response takes place and you have it's called cirrhosis, that is a non-reversible state. However, these two states of steatosis, where there's a fatty change in the liver, and this state of hepatitis, like an alcoholic hepatitis, which is an inflammatory disease, you can see we've got exposure moves from normal liver to the steatosis. And then if you abstain from the drinking, then it can go back. The liver is highly regenerative. Like the skin, it's one of the most regenerative tissues in the body: bone, liver, skin. It really likes to have complete resolution. Hepatocytes or liver cells are very, very keen on repairing themselves. And then here you can see the inflammatory insult. You get some necrosis, inflammation. We'll talk about Mallory bodies. I'll show you some histology. But really, the continued exposure or the repeated attacks that lead to scarring is irreversible. So I would say steatosis and hepatitis, so normal, this would be on the same level of severity. And then the next level of severity would be cirrhosis. Some textbooks kind of tell you, steatosis is stage 1, hepatitis is stage 2, and then cirrhosis is stage 3. But really, these two are more similar than different, and they are more apt to return to normal function as long as there's no scarring. Okay? Alcohol consumption is the leading cause of liver disease in the United States, which is one of the reasons that we focus on it in this particular segment. So what are the risk factors? Well, there's definitely a genetic risk factor. Not all livers are the same. Some individuals have larger livers, more highly metabolic livers. There's evidence to suggest that alcoholism or addictive behavior, there may be a genetic component to that. If families have a history of alcoholism in the family, that is a difficult trend to break. The question is it all genetics, or is there some environmental influences there? Difficult to separate those out. But there is a genetic component. There's no question about that. Environmental, risky use. What is risky use? It's defined in so many different ways. Okay. The slide says greater than 4 drinks per occasion on a regular basis. 4 drinks, 4 beers, 4 cocktails, like with 1 ounce of hard liquor, 4 glasses of wine. I mean, that's a decent amount of alcohol, and on a regular basis. I mean, if you're doing that every day of the week, 4 drinks, that's probably in the category of risky use. Okay. More recently, in the United States, the CDC has kind of described that for women, more than 3 drinks in a day or more than 7 per week is considered risky. So that's a little bit different than that definition. For men, same source, CDC, more than 4 drinks in a day or more than 14 per week is considered risky. So 14 would be like 2 drinks a day every day, considered risky. Again, why is it different for men and women? Well, usually men are larger than women, so their livers are bigger. So metabolically, they can process more alcohol more quickly. But again, there's all sorts of definitions. I mean, what you could find, online or, in chat is probably some risk use that you're under to make you feel good about it, right? Every patient could do that. You look for the data that you're trying to find and say, oh, I'm not risky because someone will say, some publications may say more than 6 drinks on a regular basis. Well, as long as I stay at 5 and I skip Sunday, I'm good, right? So there's always going to be data out there to support, what it is that you're trying to conclude. But, you can be your own judge and talking to patients. I mean, you'll have to evaluate. But that's why when you go to the physician, they're always asking about tobacco and alcohol use, and now drug use, right? Whether it's recreational or illicit drug use. Usually a good indication is if, you have a hangover the next day, that was probably risky use. No hangover, probably not as risky. But there's been more data pointing to binge drinking as being problematic, being just as dangerous as regular risky use. So, I mean, some of the more recent publications, and I'm a little reluctant to actually point to some of these data because it's early, but the data that's come out this year is kind of pointed to there's really no identifiable safe level of alcohol consumption. And if you think about it, kind of back to the respiratory lecture, or respiratory concepts, like vaping and smoking, we weren't really designed to breathe air that has stuff in it or is dirty, right? Well, alcohol is a poison. Like we consume it and we detoxify it. And the reason we feel the effects of alcohol or the buzz is because of an intermediate. And when you consume faster than the liver can detoxify, that's when you feel the effects of alcohol. So it's not surprising to conclude that probably the safest behavior is no alcohol. But, again, culturally, socially, maybe that's not the place that most individuals want to be. So use your best judgment here. The etiology of alcoholic liver disease is excessive alcohol consumption. It damages the microtubules, it damages the mitochondria, it ruins the membrane fluidity of the liver, and it puts you at risk of moving into these different stages of liver disease. So let's unpack these one at a time. So first up, we'll talk about steatosis. And we're going to talk about the morphological differences between the three different stages. So steatosis, you have a large, soft yellow, kind of greasy liver. You get cholestasis, where bile is not flowing. A steatotic liver, for a lot of physicians that still do physical exam, they may be able to palpate the liver and feel that it feels more firm. It feels more enlarged and it feels softer than normal because of really kind of the fatty content. The fatty content makes it more soft, but it's enlarged. In steatotic livers, you often find perivenual fibrosis, so fibrosis around the venules or the small veins that are in the liver. Second up is alcoholic hepatitis. So now here you get the liver cell or the hepatocyte starting to swell, enlarging. You get the formation of Mallory bodies. These are cells that produce a lot of hyaline cartilage. They're made up of a lot of eosinophilic components and keratin filamental proteins. The right bottom picture is images of alcoholic hepatitis. On the right lower image, you got Mallory bodies that can be seen where these cells that are enlarged, you can see the purple nuclei and then the larger cell and the pink around it. All of that extra pink is hyaline that's starting to deposit. The left image is a normal liver sample. So you can kind of see the difference between alcoholic hepatitis with Mallory bodies. All of these circular looking cells that are enlarged and they're replacing the hepatocyte. Then we move more aggressively to cirrhotic liver, where you've got micronodules. It becomes shrunken. You get non-fatty scarring. You get fibrotic deposition, excessive collagen scarring that takes place in the cirrhotic liver. So let's talk first about steatosis, the pathogenesis of steatosis. So the Pathogenesis of steatosis, it's really referred to as also fatty liver disease. The liver becomes fatty. And you can see from this histology here, all of these adipocytes, like these wide open vacuoles that you know from 201 and 202 as being fat cells instead of liver cells. So what's happening here? Well, we've got in this reaction up at the top, you've got alcohol, ETOH or ethanol, plus NAD plus. That combination leads to acetaldehyde plus NADH. And that breaks down into acetate. The alcohol dehydrogenase enzyme is what catalyzes a reaction that's above. And this makes excessive hydrogen ion, free hydrogen ion concentration, and NADH. And NADH specifically as a byproduct of the breakdown of alcohol, it inhibits the breakdown of fat or lipolysis or making energy from fat, which the liver likes to do. It likes to make energy from fat. Well, NADH blocks that, and it encourages the production of new fat cells, which is why you get this phenotype. And this is reversible unless you have any fibrotic scarring that's taking place, which we've talked about a couple of times. So let me ask this question before we continue. Alcohol abuse is greatest among which age group? 15 to 17-year-olds, 18 to 29-year-olds, 30 to 54-year-olds, and 55 and older. That's right. 18 to 29-year-olds. This classroom, right? Your peers. Well, I know some old people that can really crush it. This is where the danger is right here. Okay, this age group that you all are in. And I mean, it persists for a while. And there's really no, probably no safe age to be consuming poison on a regular basis in high amounts. I mean, that's exactly what we're talking about, right? Now, don't get me wrong, I'd love to have a glass of wine, I'd love to have a drink every now and then, but these data are pretty eye-opening about how frequently we do that. Tends to increase during holiday season, that's upon us. So just, be aware of that. Goes up during the winter months, because there's not as maybe much to do. It's cold outside, so helps keep you warm, I guess. All right, pathogenesis of alcoholic hepatitis. So this acetaldehyde from this reaction, this intermediate, is what I was talking about before. This is actually a liver toxin, what we refer to as a hepatotoxin. So this intermediate acetaldehyde that comes from the breakdown of alcohol and NAD plus acetaldehyde plus NADH leading to acetate, when this accumulates and doesn't move quick enough, then you have a liver toxin. And you also have the effects of alcohol. So the same thing that's acetaldehyde that's causing trauma to the liver is what's leading to the buzz effect. If this happens over and over and over again, you start stimulating necrosis. You get tremendous amount of inflammation, white blood cells come on the scene. You get TNF alpha, which is an inflammatory cytokine that's made from Kupffer cells that are in the liver. These are a special type of liver macrophage. Like the microglial cells that we saw in the central nervous system, the Kupffer cells are the liver macrophage. So they're the scavenger, they're the phagocytic cell that's cleaning up the debris or trying to take care of the effects of the breakdown of tissue and scarring due to chronic inflammation or chronic inflammatory insult. This causes liver cell or hepatocyte damage. The stellate cells are activated. These stellate cells manufacture large amounts of collagen. And in the making of a large amount of collagen, they lay down a fibrotic matrix. And you can see in this diagram the normal liver on the left. So here's our Kupffer cell. This is a macrophage-like cell in the liver. You can sort of appreciate this stellate cell that's dormant, or quiescent is another name for that. And in a fibrotic liver, these stellate cells actually are activated and they release more collagen, these collagen fibers, than they did in the normal phenotype. And that's what's leading down to a lot of the scarring that's taking place. You also activate the macrophage-like cell, and you create a chronic inflammation response in the liver tissue. In this picture here, this is a picture of alcoholic hepatitis that you can, I think, highlight the mammillary bodies that are present. Again, this is a nice view of this darker stained pink is these mammillary body phenotypes. Here's a really nice one with the nucleus like on the far right edge, like at the 3 o'clock position, the nucleus in purple, and then the mammillary body cytoplasm in dark pink. Another one right here, another one right here, and another one right here. So mammillary body presence is indicative of alcoholic hepatitis. Again, reversible, arguably maybe a little bit more aggressive than fatty change, which we saw here with steatosis. Reversible as long as there's no fibrotic scarring. You can lay down extra collagen, but if you go way too much and you create a scar, we're in the next category of cirrhotic liver, and that is not reversible. Okay, so cirrhotic liver. Pathogenesis. This is fibrosis where these stellate cells get repetitive injury. So these guys are repetitively injured and they're activated to a greater extent in alcoholic cirrhosis. The macrophages release tremendous amounts of growth factors. You get hypertrophy or enlargement, aggressive enlargement of the liver, but a lot of it is occupied by scar. So even though it gets bigger, it's not really functional. Repeated cycles of ethanol or alcohol damage and fibrosis propagates this pathology. You get the architecture changing dramatically and creating a tremendous amount of alcoholic portal hypertension. In patients that are alcoholics, about 15 to 25% of that population develops a cirrhotic liver. And it won't be reversed, so if it fails, what can you do about it? Transplant. That's right. Now, the ethical dilemma is, well, if they burn through their first liver based on their life decisions, what happens when we give them another one? Right? So younger patients that are rehabilitated have a higher chance of getting a transplant. Older patients with a long history of alcohol abuse, less likely. Not a decision I have to make, thank goodness, but I mean, you can understand sort of the dilemma there on where to use the liver, right? What are we looking at here? Well, gross image on the left, microscopic image on the right. Gross image on the left of the liver, it's bumpy. If you run your hand over it, it would be bumpy. There's nodules on the surface of the liver at autopsy. What are they from? Mason's trichrome on the right. This highlights collagen scarring. Everything in blue is excessive amounts of collagen. The pink is areas of the liver that have basically scarred over and are necrotic. So you can see all the excessive purple or blue, which is excessive collagen that's being laid down. And you can see these local areas like nodules that are necrotic tissue. And if you run your hand over the surface of this, you see how this is not smooth, but it's bumpy. That's where these bumps are coming from. So, how do these three diseases interrelate? Well, back to this picture. And so this hyperplastic nodules that's on this image, and see how it's bumpy? That's what we were just talking about. How do they relate? Normal liver up top. Alcohol abuse, first stage might be a fatty change. Get a lot of lipogenesis. You get a soft, slightly enlarged liver on palpation. You abstain from the alcohol, it goes back to normal. More severe exposure, alcoholic hepatitis, you have some chronic inflammation, you develop Mallory bodies, you stimulate some Kupffer cells, the stellate cells start making collagen excessively, maybe a little bit of scarring, but it's minimal. You abstain, it goes back to normal function. It repeats, repeated attack, continued exposure. You get excessive fibrosis, excessive scarring of the liver, non-reversible, and the liver will end up failing. Sort of in a chart-like diagram here or list, clinical manifestations, steatosis, enlarged liver, elevated bilirubin. Alcoholic hepatitis, general bad feeling, like malaise. It's kind of like feeling when you have the flu, you just feel kind of crummy. So general malaise, discomfort, anorexic, a lot of weight loss that takes place in these patients. They're not making enough energy. The liver is tender because it's inflamed, just like if you had a twisted ankle and it was inflamed, it would be tender to touch. So the liver itself is tender upon palpation. Hyperbilirubinemia, too much bilirubin, jaundice, yellow eyes, alcoholic cirrhotic liver. Now it's portal hypertension, ascites. That's that fluid accumulation in the peritoneal cavity. You get a lot of peripheral edema, right? Enlarged bellies, distended abdomens, probably fluid collecting in the feet and the legs, the lower extremities. Malaise, weakness, weight loss, and jaundice as well. Okay, not fun stuff, but trying to give you some insight into, unfortunately, something that really impacts our society, and you'll probably be dealing with in the future. That's all I have for you. Appreciate your attention. We'll see you next time.